So hello, good afternoon to everybody. Congratulations for the meeting. I would like to thank the organizers for the opportunity, especially Lucas Rasulic, for the opportunity to speak about cranial fistula. It is a big topic, that's why I'm going quickly to my first slide. This is my statement to start with. May sound a bit provocative. Dural fistulae constitute the most confusing topic in the neurosurgical literature, in my opinion. This is the content of my presentation. There are two crucial points. One, how we define the location, and second, the weaknesses of the use classifications. What I'm going to claim is actually that if we fix the issue of location, in reality, we do not need classifications much. And how this can be done? Again, anatomy is the answer. So on the right is a typical short definition of a dural fistula as it often appears in the literature. You see here, located within the dura. On the left is a fistula exactly located within the dura, between the mid-meningeal artery branches and dural veins. It is here now magnified view. It is exactly how one could imagine a typical dural shunt. Dural arteries in red connected to dural veins in blue. However, this is not the case. This pattern is practically exceptional, observed almost always in traumatic dural fistulae. It can happen theoretically in any location, and as a rule does not require treatment. This is an example of a iatrogenic traumatic lesion after EVD. You see it in yellow. Although this should be the typical fistula, when we speak about dural fistula in daily practice, we do not have this in mind. So it is not this location where fistulae usually occur. I will come back to this later. So how can we control how we understand this entity and how we perform with the analysis of these cases? The best way to do this is to check our medical reports and our related publications. This is a real example from a medical report below the English translation. My comment shortly. Why is this confusing? Vermis is a parenchymal structure of the cerebellum, has nothing to do with the actual location of the lesion. We describe the lesion as a torcular shunt and claim that this is Cognard type 4. My comment, a real fistula of a torcular cannot be a Cognard type 4. So it is not the torcular, it is the inferior vermian vein, the exact location. The information is still there. You can realize it despite the noise and even without looking at the images. Even more confusion, the so-called temporopolar location. This rough, unspecific, and vague description is the rule in many reports. You see it often. Of course, it is convenient because you avoid precision. The pole of temporal lobe cannot be the location of any dural fistula. Why? Simply because it is not a dural location. Otherwise, regarding the report, even if you don't see the images, you can say that the fistula draining into the cavernous sinus and the sphenoparietal sinus cannot be Cognard 3. More on this location. This topography is also called medial sphenoid wing. So here it is such a fistula in a case report. And believe me, this is an example of a monumental confusion in the literature exacerbated by the confusing classification Cognard, published in a leading journal, Neurosurgery, and coming from a leading institution. Unfortunately, it was published, and this is also indicative of the reviewer's understanding as well. The authors describe here that the fistula drains paradoxically in the basal vein to the straight sinus, therefore it is type 2. However, they insist it should be considered aggressive. So we are dealing with a complete ignorance of the relevant anatomy. when we analyze angiography in this way. Below is my comment, you can find it. Also, by the way, the arterial pattern is completely relevant with regard to classification or characterization of a fistula. You can simply forget this. Now, what people do not often understand, what we see in the angiography of a dural fistula are all pre-existing veins. There is no de novo vein. Therefore, you have to imagine how the original normal anatomy was. This is the key of understanding. In this particular case, you see on the left, the normal anatomy in that area. There is at least one vein, the anterior medial temporal vein. This vein is cut here, but you see the exit either to the cavernous or to the sphenoparietal sinus. In a fistula, this vein is getting occluded, and this is the actual site location of the fistula. Therefore, the vein is the dictating structure. It defines the shunt type, it determines the clinics, it defines the treatment. Let me say it this way. If this is a medial sphenoid wing dural fistula, then this should be a planum sphenoidale aneurysm. But it is actually an ACOM aneurysm. We made a progress in that respect. We do not name arteries according to the adjacent bone. However, concerning dural fistulae, we are still in the era of naming vascular structures according to the adjacent bone. Why? Simply because we ignore the venous anatomy. Another example, there is plenty in the literature. The whole paper might be good, published in Journal of Neurosurgery, but it has at least one fundamental mistake. It is a mistake linked to the original analysis of the angiographic images. You see here in the cycle that 40 cases had no reflux according to the authors. The locations were tentorium, cavernous sinus, transverse sinus, and of course, hypoglossal canal. Question, can it be that a tentorial fistula does not have a reflux? Is that possible? No, it is not possible. Therefore, there is a mistake here. Sorry, and this mistake has to do with definitions and misinterpretation of the angiography. This is not unusual. Now, this is an unbelievable case with 3 different classification descriptions for the same patient in the same report. All these are photos from the same report. You see type 2, type 3, type 4. Believe me, this is true. Why such a confusion? Because the confusing Cognard classification defines the grade 4 as a grade 3 with venous ectasia. This fistula, which is basically according to Cognard should be type 2, cannot have an ectasia, is not allowed. No such a provision is made. That is why people get confused. This is not their fault, it's fault of the classification. Now, let me become a bit more sharp or a bit more naughty. This is only for those who are not yet convinced about the confusion I'm talking about. The others who are convinced can ignore it. They may have an espresso in the meanwhile. So this is a case presented in an official neuroradiology meeting, web seminar in the Corona times. We see here a dural fistula of the transverse sinus with reflux to the straight sinus. Therefore, we have retrograde flow to the sinus first, and second, reflux to the cortical veins. What does it mean in terms of Cognard classification? Here at the bottom right, you see that it is type 2A and 2B. Is there any doubt about that? I think no, it is very, very clear. Now, have a look here. This is the screen of the web seminar. This is the case I'm talking about. And this is how it was described, 2B. And to your surprise, this is Cognard himself. Dear Christophe Cognard, I think I do not need to comment further. Mistakes are human, certainly may happen, but some schemes are unnecessarily complex and more prone to mistakes than others. This is the bottom line. Conclusion, too many mistakes in the way we analyze and describe dural fistula in our reports, which is certainly reflected in the literature. Now, let's move to this quick quiz. Where a dura shunt can be located? Anywhere in the dura, always in the pre-existing venous structures, or within the wall of the sinus? Certainly, the last answer is wrong. The second is the correct, and this vein structure can be a sinus, can be an emissary vein, can be a bridging vein. And this bridging vein can be found theoretically anywhere in the dura, more often, however, near the sinuses. Now, which are these venous structures? And this introduces us to the concept of levels. This is just a scheme, a simulation of the real anatomy. For example, this could be the Labbe vein, the transverse sinus, and the mastoid emissary vein. The usually encountered dural fistulae can be located in one of these three levels of the cranial venous system. From inside to outside, bridging vein exit, dural sinus, emissary vein. On purpose, I ignore the other two levels, the veins of the bone and the dura itself with its dural veins. Why? Because these are rare and somehow special fistulae. So we focus on these three levels. Therefore, we may have fistulae of the bridging vein, fistulae of the sinus, and fistulae of the emissary vein. I skip this. Bridging veins are found in many different locations near the sinuses, but also away from the large or typical sinuses, as in the tentorium, or in the convexity, far away from any sinus. In red, the dural exit of the vein into an atypical sinus, shown in black. These are atypical, not so rare, and no-name sinuses. So the concept of level is not identical with topography. Topography is what we usually see in the literature, like anterior cranial fossa, tentorium, superior sagittal sinus. However, there is a link between topography and level. For example, if we take the topography tentorium, for this topography, only fistulae of a certain level can occur. The bridging vein fistulae. Why? Exactly because of the venous anatomy in that area. This is why they are always aggressive. The same more or less applies for the anterior cranial fossa. Analyzing a dural fistula, we need to describe the level mostly and say, for example, this is a bridging vein fistula. But also the topography, it is relevant to say, for example, it is a dorsal medullary bridging vein, normally emptying to the marginal sinus, as well as, so the level first, stenosis or occlusions, because these two factors define whether any type of fistula has or will develop reflux or not in the future. And if it has a reflux, we need to describe the impact on the brain. This is the strain, and can be either structural as ectasia or functional as congestion, or both. This is the DES scheme, D for direct reflux, E for exclusive reflux, and S for strain of the brain. Now, so there is a spectrum of different locations and different fistulae patterns depending primarily on the location itself. I'm showing here only the two extremes of the spectrum. On the left one side of the spectrum with a benign emissary fistula, emissary vein fistula. This is the most benign one with no reflux. Why? Mostly because it is located far away from the cortical veins. And on the other side, the bridging vein fistula, by definition, with reflux. Why? Because it is located exactly on the cortical vein exit. therefore the most aggressive fistula of the other side of the spectrum. In conclusion, on the right side, we see a bridging vein with direct reflux, but when the exit of the vein is completely occluded, it's going to be also exclusive. And this is the rule. And with clear signs of strain of the cerebral venous system, you see here ectasia and congestion. And this is the most dangerous variety. I'm not going to show you all varieties. I'm going very quickly through all these potential varieties of the fistulae. And I'm moving quickly to the treatment lines. This should be clear. Embolization has a leading role in the treatment of dural fistulae. More in details. For benign fistulae without reflux, mostly follow-up or embolization is recommended if symptoms affect the quality of life of the patient. Second, for all sinus or emissary vein fistulae, embolization is most of the case alone effective. 3, for bridging vein fistulae, embolization is mostly effective as well. However, in case of failure, we have an excellent alternative. This is now the exact role of surgery, because for this specific type, it can be very effective with a small craniotomy and simple clip disconnection. Where is the major problem that many neurosurgeons have? Is the question how reliably we can distinguish such a candidate in case of embolization failure. This is what we described in this paper. Let me show you just this case and finish. This is usually called a medial sphenoid wing fistula, but certainly the description does not say anything. The right description is a fistula of the middle cerebral vein at the dural exit of the vein. As you know, this vein may empty into the cavernous sinus or may empty into the sphenoparietal sinus. I'm not going into details because there are some controversies here. If somebody tells you that this is a bridging vein fistula of this vein, then we have the option of clipping as well, exactly in this location in case of endovascular failure. In this particular case, however, there is an anatomic variation. This is the angiography of the fistula. The anatomic variation, the clip is where you could put the clip. The anatomic variation is this sphenobasal sinus connected to the vein, and through this, one could, and I could apply some coils endovascularly, which is like an endovascular clip, and disconnect the vein very elegantly. The same thing, but without craniotomy. And this is on the lower left of the image, a few coils which act exactly as an endovascular clip. And this is the MR control confirming the result. Thank you very much for your attention.